Welcome back to Catalyst University. My name is Kevin Tokoff. Please make sure to like this video and subscribe to my channel for future videos and notifications. In this video, we're going to be looking at the physical exam to diagnose a lumbar radiculopathy. But before we do that, let's differentiate these two groups right here, which are both a part of the low back pain classification system. At the bottom here, we have the radiculopathy subgroup. And up here we have the directional preference subgroup. And remember, with directional preference, there's actually two of them. Technically three, although the first two are most common. There's the extension directional preference and the flexion directional preference, which really is lumbar spinal stenosis. Now, with the directional preference for extension, remember that in general, this implies that the symptoms are going to centralize with lumbar extension, which makes sense because that's their directional preference, and they tend to peripheralize with lumbar flexion. Okay? So when you have this centralization and peripheralization that are opposite movements, or at least different movements, that constitutes a directional preference. Okay? Now, on a very superficial level, these two subgroups can actually present very similarly. They both can technically have radicular symptoms. But it's important to differentiate patients that fall into the directional preference from those that fall into the radiculopathy because the treatment is going to be somewhat different. Okay? And that leads to the question, how do you differentiate these? Well, look at this table over here. So on the left, we have the specific exercise group. So technically, the functional optimization group is what it's called. And then radiculopathies over here on the right. Now, the first question here is, do the symptoms peripheralize? And in both groups, they do. If we look at the directional preference for extension, we said they peripheralize with lumbar flexion. In a classic radiculopathy, the peripheralization tends to occur whenever you do movements that narrow the intervertebral foramina, and that potentially causes nerve root compression. And those movements are going to be lumbar extension, ipsilateral side bending, and ipsilateral rotation. In other words, if they had a left radiculopathy, it would be lumbar extension, left side bending, and left rotation that would cause that intervertebral foramina, or foramen I should say, singular, to close down and compress that nerve root. Okay? So they both peripheralize, but they do peripheralize to different extents. Okay? Then if we look at, do they centralize? Well, with directional preference, yeah, they do tend to centralize. Okay, so if somebody's going to fall into this category, they better peripheralize with one movement, but they also have to centralize with the other. Okay, if you have a patient that you cannot get to centralize, that's going to suggest that they may fit better into the radiculopathy group. Okay, so that's one big difference, is if you can get them to centralize, it's more likely going to be that specific exercise group, the directional preference. If you can't get them to centralize, probably better to put them in that radiculopathy category. Now the next part is the signs and symptoms of the pain, in particular with the peripheralization, right? So in the specific exercise group, these patients tend to do better if their peripheralization does not go past the knee. Okay, so you can have, for this directional preference and extension, the symptoms going distal to the buttock, but not below the knee. As long as they remain in the thigh, just above the knee, they can probably do okay in this group. But if they go past the knee, into the shin, the calf, even down to the foot, that makes it less likely that they'll do well in the directional preference group and more likely that you'll put them in the radiculopathy category. Okay, so in the radiculopathy category, the symptoms go from the lumbar spine, they can go to the knee, but they can even go to the foot. So they can peripheralize through the entire lower extremity. And really that centralization and how far the pain goes down, those are two really big factors that differentiate which group a patient is going to fall into, directional preference or radiculopathy. We're now going to shift gears and talk about diagnosing a lumbar radiculopathy. What rules it up, what rules it down. But before that, a quick note on test item clusters. So for the cervical radiculopathy, we do have a test item cluster, and that's Wayner's cluster. That's its special name, and it has 4 items in it. 3 of them are going to be provocative tests, and then the one easing test is the distraction test. So the 3 provocative tests, the first one being the most important, upper limb tension test A, which is the median nerve bias, and then Sperling's test, And this last one over here is another provocative test. This is really just active cervical rotation. You have them undergo cervical rotation, and if it's positive, it will reproduce neurological symptoms before they get to 60 degrees. Okay? So that's the cervical radiculopathy test item cluster. For the lumbar radiculopathy, there isn't any. And it's not to say that eventually they won't come up with one, but currently there is no test item cluster. Instead, we have specific special tests that are used. And here's some of the recommended tests that we're about to discuss. So we'll start with the slump test, and then you have the straight leg raise test, and then the related crossed straight leg raise test, and then the femoral nerve tension test. Before we go into these 4 special tests, let's review some basics on a classic lumbar radiculopathy and understand that not every patient in real life is going to fit this cookie cutter list right here. But some things to look out for. Number 1, their signs and symptoms, remember, can extend distal to the buttocks and also below the knees. That's not to say that those neurological symptoms have to go below the knee. They could remain above the knee. But for a radiculopathy, you have the possibility that those neurological symptoms will go all the way down to the foot, basically the entire lower extremity. Okay? Also, we have these signs and symptoms of classic lumbar radiculopathy, things that compress the nerve root by narrowing the intervertebral foramina. Remember, those are lumbar extension, ipsilateral side bending, and ipsilateral rotation. Also, there's a tendency out of these 3 that you tend to see the most peripheralization with extension, lumbar extension that is, although that's not universally for every single patient. And one of the big ones here, and we'll talk about why this is in a few minutes, is a positive cross straight leg raise. Looking at the sensitivity and specificity values, you might be able to guess why this one is so important for a lumbar radiculopathy. But you might also see a positive straight leg raise, positive slump test, positive femoral nerve test, and sometimes you may actually have the patient say that they get this pain whenever they cough or sneeze, basically things where you get a transient increase in intra-abdominal pressure, and that pressure can actually put more compression on those nerve roots, which makes the neurological symptoms peripheralize in that moment. Let's now look at these special tests in more detail. We're now going to talk about the slump test. The goal of the slump test is to rule up nerve root compression in the lumbar spine or adverse neurodynamics, especially for nerves in the hips and the lower extremities. Now, I say rule up very loosely because if we look at the psychometrics up here, you'll see that they're pretty poor. Sensitivity is only 0.44 and the specificity is only 0.58. The specificity is technically better, but it's still pretty bad. But even though it's better, that's why I say rule up here. But having a specificity of 0.58 basically means that if you have a positive slump test, there's a 58% chance that they have nerve root compression or adverse neurodynamics. It doesn't really tell us which one. So this test is okay, and it's often used in clinical practice. But really the better tests are the straight leg raise test with a sensitivity of 91% and the cross straight leg raise test of 90%. These 2 are better. And oftentimes the slump test is used when you just really need to confirm your hypothesis and you've already done the 2nd and 3rd tests right here that we'll cover later on. So the way the slump test is done is one at a time. You have the patient passively move through all these movements up here in the flowchart. And after every movement, you assess for their pain and signs and symptoms. Okay? So before we get into this video right here, let's actually go through the flowchart and make sure we understand that. The first movement is really the only one that's not passive. This you can have the patient actively do, and they're going to assume a slump or a slouch position, basically an intentionally bad posture. You'll see that in a minute. This involves thoracic and lumbar flexion. And once they do this, you then assess for their signs and symptoms and pain. Then you're going to perform passive cervical flexion on them. You're going to bend their neck down, try to touch their chin to their sternum, and then you're going to assess the further signs and symptoms and pain. Then you'll perform passive ankle dorsiflexion, and again, assess for signs and symptoms and pain. And then you perform passive knee extension, and also not shown here, you assess for their signs and symptoms and pain. And what do we mean by signs and symptoms and pain? Well, by pain, we mean the burning, shooting pain going down that lower extremity. And by signs and symptoms, we mean numbness and tingling going down that lower extremity. So lower extremity paresthesias, numbness, tingling, burning, shooting pain. And if they experience any of those at any point in this pathway, that constitutes a positive slump test. Now let's take a look at a demonstration here of the slump test. The very first thing I'm going to do is I'm going to have the patient actively slump or slouch down, intentionally get that bad posture, which involves thoracic and lumbar flexion. All of these movements right here gradually put more and more tension on the nervous system. So tension on the nerve roots, both lumbar and sacral, tension on peripheral nerves going down the lower extremities. Okay. And once we get into this position, I'm going to assess for their symptoms and pain. Basically, any one of those 3 lower extremity paresthesias. Okay? If they don't have any of those symptoms yet, then I'm going to take their neck and passively move it into cervical flexion. Cervical flexion also puts tension on the nervous system. Once I move them into that position, I'm going to reassess for any of those lower extremity paresthesias. Assuming they don't have any at that point, I'm then going to passively dorsiflex their ankle. So I reach down and dorsiflex the ankle. Once again, I'm going to reassess for any of those 3 lower extremity paresthesias. Then I'm going to passively dorsiflex her ankle. You'll notice at this point that I'm doing everything on the left lower extremity. So am I expecting any paresthesias on the right side? No, I'm only expecting any if they're going to come on the left side, the side that I'm doing these passive movements on. Okay, so once I dorsiflex that left ankle, I'm going to reassess for any of those 3 lower extremity paresthesias on the left side. Okay, then I'm going to passively extend the knee, and at any point along that knee extension, I'm going to reassess for any of those 3 lower extremity paresthesias. Now, unless you just have really, really good nerves, this position right here is not comfortable for anybody. And the vast majority of people are going to feel some tension on their nervous system in this position. Does that constitute a positive test? No. In order to be a positive test, it has to reproduce any of those 3 paresthesias: numbness, tingling, or burning, shooting pain. Now, each one of these successive movements right here puts more and more tension on the nervous system. That being said, it really doesn't matter in theory what order you do them in. In practice, the slump and cervical flexion are always done in this order. However, the order of these last 2 movements really just depends on clinician preference. My personal preference is to do dorsiflexion first, followed by knee extension, but some clinicians will do the knee extension first, followed by dorsiflexion. Regardless of what order you do them in, we're all still going to the same final position. So if a patient is going to have a positive test, it doesn't matter which order you do these in. So you do whichever you prefer. Dorsiflexion, knee extension, the order does not matter. But in the end, a positive test is still the same. Reproduction of any of those 3 lower extremity paresthesias. We're now going to discuss the straight leg raise test, and then after that, we'll look at the cross straight leg raise test. So the goal of the straight leg raise test is to rule down nerve root compression in the lumbar spine. The key word here is rule down. So if we look at the psychometrics of the straight leg raise tests, it has a very low specificity of 0.26, but the sensitivity is actually pretty darn good, 0.91 or 91%. This means that if you conduct a straight leg raise test and the result is negative, there's a 91% chance that that patient does not have nerve root compression in the lumbar spine. So is the straight leg raise test good for ruling up nerve root compression? No, it's good for ruling it out, or ruling it down, in other words. So how do you perform a straight leg raise test? We'll look at a picture first and then delve into the video in the next slide. But the basic idea is the practitioner is going to passively elevate the affected leg slowly from the table to at least 45 degrees. All the movement occurs about the hip joint, and the knee is kept completely straight throughout the duration of the movement. Now, the reason I say it has to be passively elevated to at least 45 degrees is because if somebody actually has nerve root compression in the lumbar spine, if they're going to have symptoms, it's going to occur usually between 30 and 45 degrees. So if you're only bringing it up 10 to 15 degrees, you're probably not going to see those radicular symptoms, and so you're going to get a false negative. It really needs to be at least 35 to 45 degrees, and that's usually the range where you will see those radicular symptoms. Okay? So what constitutes a positive test? It's really going to be reproduction of the patient's pain and or their signs and symptoms. By pain, we mean the burning, shooting pain that's associated with nerve root compression. By signs and symptoms, we mean numbness or tingling. So in general, we're talking about ipsilateral lower extremity paresthesias. Now, why do I mention ipsilateral lower extremity paresthesias? To understand that, let's suppose we have this patient right here who complains of back pain, and particular movements and positions cause that numbness or tingling or burning shooting pain to go down their left lower extremity right here. So if you passively lift up their left lower extremity to 30 or 45 degrees and they get reproduction of those same paresthesias going down that same left lower extremity, that would constitute a positive test. And it doesn't have to be all three of the paresthesias. It can be just one of them. Again, numbness, tingling, or burning, shooting pain. So here's the straight leg raise test in real time. Patient begins in supine, and I'm going to take that leg, keep the knee straight, and passively elevate the leg until we get reproduction of those paresthesias in that leg. So what would be my setup for this test? Patient would complain of low back pain and associated paresthesias going down the left lower extremity. That's why I did the left leg. This is an ipsilateral test. And if I got the reproduction of those paresthesias, it would be a positive straight leg raise test. Now, if you just do that, it might be sufficient to call it positive, but you can do something further to really confirm that you've got nerve root compression. So from that position, you see the foot right here, you can also dorsiflex that ankle. So the practitioner would passively dorsiflex the ankle, and what you would expect is that to actually aggravate those neurological symptoms, make them a little bit worse. So make the numbness a little worse, the tingling a little worse, the burning shooting a little bit worse. The reason for that is dorsiflexion puts further tension on those nerve roots in this position. Okay? Likewise, you could also passively plantar flex the ankle. This actually relieves some of that tension on the nerve roots, so we would expect this passive movement to actually ease those same neurological symptoms. Now, if the patient's symptoms are extremely irritable and severe, you're probably not going to want to dorsiflex the ankle because that's going to further aggravate the symptoms, and you really don't want to risk that. You'll just simply go with plantar flexion, that is passive plantar flexion, to get easing of their neurological symptoms. And if they do ease with passive plantar flexion, that further rules up that you have a positive test. Before we go to the cross straight leg raise test, let's look at these angles down here and see what it means if a patient experiences pain within these ranges. But we need to keep in mind that for the straight leg raise test, a positive test has to be ipsilateral lower extremity paresthesias, any of those three paresthesias. Now, if we start doing the straight leg raise test and the patient experiences pain between 0 and 15 degrees, it usually means one of three things. It could be a hip pathology, which means we need to qualify the nature of the pain. So if the patient has pain, we need to ask them what it is, because it may not be those paresthesias. If it's not, it could be a hip pathology. They may point to their hip and they may deny that it's paresthesias. It also could be, in rare cases, very severe nerve root inflammation. Again, I would expect to have those paresthesias if they're present between 30 and 45 degrees. But if the nerve root inflammation or damage or irritation is very severe, you could have it before that 30 degrees. It also could be malingering, so the patient is just grossly exaggerating their symptoms or lying about them for some personal reason. Okay? But this is also not very common. Then between 15 and 30 degrees, it could also still mean a hip pathology, and you could also have severe nerve root inflammation as well. Now, between 30 and 45 degrees, this is really where you see those lower extremity paresthesias. Okay? And those paresthesias can come from one of two sources, either a true radiculopathy, which is where the nerve roots are being compressed, Or you can have a sciatic nerve that's being compressed. A lot of times the sciatic nerve can be compressed by a tight piriformis muscle. It's not the only thing that can cause it. When the piriformis muscle is tight, it actually compresses the sciatic nerve that actually emerges beneath it. Okay? And so we'll talk about how to differentiate those two things in just a minute. Between 45 and 60 degrees, we can also get paresthesias there. However, if you start to see them in this range, it's probably not due to a true radiculopathy. It's probably more sciatic nerve. However, regardless of where in those two ranges you see those paresthesias, you can rule up a nerve root involvement by performing that ankle dorsiflexion. Remember, that's aggravating. So if ankle dorsiflexion makes those paresthesias worse, it's more likely due to a nerve root compression than the sciatic nerve. Okay. Now, normally you won't need to go this high, but if they have pain between 70 and 90 degrees, that's normally due to a pathology of the sacroiliac or SI joint. And then if they have pain beyond 90 degrees, that's normally due to lumbar hypermobility. Now let's talk about the cross straight leg raise test. This is very similar to the straight leg raise test, but there's two major differences. The first is the goal. With the crossed form of this, it's to rule up nerve root compression, emphasis on rule up. If we look at the psychometrics of this test, it makes sense. The sensitivity is only 0.28, very poor, but the specificity is high. It's 0.90 or 90%, meaning if somebody has a positive cross straight leg raise test, there's a 90% chance that they actually have nerve root compression. That's the first difference. The second major difference is which leg we're elevating. So notice here for this test, we're passively elevating the unaffected leg or opposite leg solely from the table to at least 45 degrees. So the same type of patient, we have a patient complaining of low back pain and associated paresthesias going down the left lower extremity. So if their paresthesias go down the left lower extremity, we're going to elevate the right leg. And we elevate it in exactly the same way, but we're still looking for those paresthesias going down the left lower extremity. So whatever leg they complain of paresthesias in, you're always elevating the opposite leg. And this test helps to rule up that nerve root compression. Okay? So here's the cross straight leg raise test in real time. We have the same patient. They complain of left lower extremity paresthesias. So which leg am I going to elevate? It's the right one. Okay? So same thing. I'm going to keep the knee straight and passively elevate the right leg up. Now, let's suppose this is where they start to feel those paresthesias. Are they going to feel it in the right side? No. They're going to feel it in the contralateral lower extremity, meaning the one that's still down, the left lower extremity. So it's always going to be in the opposite leg. From here, you can do a lot of the same stuff that we saw before. You can passively dorsiflex the ankle, but know that that's going to aggravate neurological symptoms, including the numbness, the tingling, the burning, shooting pain. You can also passively plantar flex the ankle, which should actually ease those neurological symptoms. And if you plantar flex and it eases those symptoms, that further rules up that you have a positive test. Just like if you dorsiflex the ankle and it aggravates those symptoms, that also further rules up that you have a positive test. Now we're going to look at the femoral nerve tension test. The goal of this test is to assess for compression of either the femoral nerve itself or the femoral nerve roots. Remember that the femoral nerve originates from the lumbar plexus, specifically nerve roots L2, L3, and L4, with a major contribution coming from L4. Remember that L4 in just a minute. Now, you'll notice that the femoral nerve tension test has unknown psychometric properties. They have not been determined. They have not been subjected to a rigorous study. So we can't say necessarily that it's good for ruling up. We can't say that it's good at ruling down. For all we know, it might be bad at both of those things, but it does have an important use. If we look at these first three tests, the slump test, the straight leg raise test, and the cross straight leg raise test, there's one big problem with all three of these. And it's in patients who have compression of the L4 nerve root. So if you perform these tests on a patient with an L4 nerve root compression, they may actually fail to provoke their symptoms. There's just something weird with the L4 nerve root. So if you have a patient that has any of those lower extremity paresthesias, numbness, tingling, burning, shooting pain, but these first three tests all come up negative and you're just kind of scratching your head, you might consider giving the femoral nerve tension test because it could be a nerve root compression of L4 that was failed to be provoked by these 3 tests. Okay? And this test specifically puts that tension on the femoral nerve and the femoral nerve roots, particularly L4. So how do you perform the femoral nerve tension test? Well, you'll begin with the patient in prone like you see here, and then you're going to take their knee and passively flex it to 90 degrees. Then you'll take their entire lower extremity and elevate the thigh at the hip joint, and you're moving it into hip extension while maintaining this knee flexion. Okay? So what constitutes a positive test? Well, when I do this movement, it would have to reproduce their pain and or signs and symptoms. And by pain, we mean burning, shooting pain in this lower extremity. And by signs and symptoms, we mean numbness and tingling in this lower extremity. So basically, ipsilateral lower extremity paresthesias, meaning whatever leg I do this on, I have to reproduce the paresthesias in that same lower extremity for this to be a positive test. So what would clue me in to do this test? Well, I would have a patient with low back pain, and they'd have associated paresthesias going down the right lower extremity, so I perform the femoral nerve tension test on the right lower extremity. So hopefully that makes sense. Thanks for tuning in. Please like, subscribe, and check out my Instagram for cool science and not science stuff.